Hi, everyone. Good to see you all. Good to be here today. Thank you for sticking around till the end of the day. The goal of this talk is really to try to demystify what interstitial lung disease is. Oh, yes, yeah, I'm sorry. Okay, better? Okay. Perfect. So the goal is really to demystify what interstitial lung disease is. You all have excellent rheumatologists that I'm sure have mentioned that term to you. Some of you may have interstitial lung disease. Others of you might be talking about screening for interstitial lung disease. And I know you've heard about it a little bit throughout the course of the day today as well. But my goal is really to help sort of understand some of the terms you might see in your reports, understand some of the parameters that we as pulmonologists are looking at to monitor interstitial lung disease, and sort of help make this less of a confusing topic, because it really can be. It kind of becomes a little bit of an alphabet soup at times. So I have no financial disclosures. Like I mentioned, big things that we're going to talk about today are what is interstitial lung disease, who's at risk for getting it, how might you know if you're at risk, what signs and symptoms might you expect to see. As a pulmonologist, what type of testing do we do to diagnose and monitor interstitial lung disease? And finally, we'll focus really in on how scleroderma-associated interstitial lung disease is treated, and we'll go through lots of the pharmacologic and non-pharmacologic management of the disease. So what is interstitial lung disease? It's an umbrella term, and it encompasses a lot of different diagnoses that can cause a combination of inflammation and or scarring or fibrosis of the lungs. It can affect the wall sacs of or the walls of the air sacs. The air sacs are called alveoli. It can affect the surrounding tissue and the space around the air sacs, which is called the interstitium. Hence that term, interstitial lung disease. And you can see from that figure that I've got on the slide, those little air sacs are tiny little air sacs that make up the lung tissue, and around those air sacs you've got that lighter pink interstitial tissue where vascular structures are running and other structures are running that become abnormal. So who is at risk for developing interstitial lung disease? There are a lot of different causes. So some of the causes of interstitial lung disease are known, and sometimes we don't know why somebody gets interstitial lung disease. And those types of lung diseases are termed idiopathic or unknown. Under the known types of interstitial lung disease, we know that different types of inhaled exposure, like asbestos, for example, or mold, can cause interstitial lung disease. Different types of drugs and radiation therapy, like chemotherapies or radiation that one might receive for their cancer, can cause ILD or interstitial lung disease. Autoimmune disease, which is certainly relevant to this crowd here, and then genetic mutations and genetic causes can also be associated with the development of ILD. So here's some of those big buckets of things that we think about, and certainly under autoimmune disease, you can see scleroderma as one of the main causes. Between 35 and 53% of patients will go on to develop ILD that have scleroderma. The lung is actually the second most affected organ in scleroderma, and so a lot of patients will become affected with this condition. In general, we tend to see that your risk for developing interstitial lung disease is the highest in those first 5 years following your diagnosis. But even longer out, we still can see there are studies showing out to 20 years after your diagnosis, you still can be diagnosed with interstitial lung disease. There are multiple risk factors that will increase your risk for developing ILD and scleroderma. We know that male gender, older age at the time of diagnosis, African American race, diffuse cutaneous scleroderma as opposed to limited disease, and then patients that have a positive SCL70 antibody in their blood are all at increased risk for developing ILD. Disease course can look very different in different people. So about a third of patients will have stable disease over time, where your lung function sort of remains constant over time. A third of patients will have disease progression followed by a period of stability, and others will have more progressive disease, where you can see from that line your lung function declines more rapidly over time. It's really difficult for us to predict which patient will fall under which arrow, and to do that, we really monitor your symptoms and your lung function and your imaging over time to sort of figure out which of those trajectories you're most likely to fall in. Interstitial lung disease is the leading cause of morbidity and mortality in scleroderma, and outcomes are worse with patients that have that fibrotic flavor of disease as opposed to that more inflammatory subtype that we talked about. A lot of times when people hear interstitial lung disease, if you Google it, the first thing that pops up is idiopathic pulmonary fibrosis, which is one of those different subtypes or flavors that we talked about on the last slide. Patients with scleroderma ILD do much better than that. So I caution you, as you're kind of learning more about ILD, researching it on your own, don't equate scleroderma ILD with idiopathic ILD, because in general, the prognosis is much more favorable for patients with scleroderma. But really important is early diagnosis and prompt initiation of treatment. Because often what happens is you might begin with a more inflammatory type of disease, but over time, if we're not vigilant and catching that and treating that, that inflammation can progress to scar tissue or fibrosis. And fibrosis or scar tissue cannot be reversed at this moment in medicine. And so what we really want to do is be proactive, catch it early, get you on treatment that targets that inflammation and prevent that irreversible scar tissue from forming. We mentioned this, you're most likely to progress within those first 5 years following disease onset. And there are a separate set of risk factors that help understand who might have progression of their lung disease. Patients with poorly controlled acid reflux that might have small amounts of acid from the stomach getting into the lungs are more likely to have progression. Patients that have substantial scar tissue on their first high-resolution CT are more likely to progress over time. If your lung function assessed by pulmonary function tests, which we'll go through shortly, are low at baseline, that is a risk factor for disease progression. If your oxygen levels are low, another risk factor. And then again, that same risk factor, that positive SCL70 antibody that confers increased risk for getting ILD, also increases your risk for your ILD for getting worse over time. So what signs and symptoms can you watch out for, and are your doctors watching out for to screen you for this disease? In general, low oxygen levels are one of the biggest things that we can see. For normal patients with normal lungs, in general, your oxygen level, when we measure it through a pulse oximeter in the clinic, should be, around 98 to 100%. And we can see that that level can become lower over time as you're developing changes in the lungs. Digital clubbing is what's pictured here on the screen, where the angle of the nail bed becomes distorted, is another sign. And then pulmonary crackles, which I think for the sake of time, we might not play the video, but it sounds like what you'd expect. If you ever had Rice Krispie cereal and poured milk over it and heard that little crackly sound, we can hear that when we listen with a stethoscope to the lungs of patients with interstitial lung disease. And that's from areas of lungs that have scar tissue that have formed, that are making that sound as you breathe in and breathe out. The most common symptom of interstitial lung disease is shortness of breath and a dry cough. And as many of you know, that is a non-specific symptom. Lots of things can make you feel short of breath. Lots of things can make you cough, including acid reflux, which might be something that you're already dealing with scleroderma. The symptoms can be really mild or even absent in early interstitial lung disease. So the absence of these symptoms doesn't necessarily mean you don't have the disease. And that shortness of breath that we talk about often occurs only when you're exerting yourself or doing some type of activity. And so some patients that might have a low baseline level of activity might not appreciate that they are short of breath with exertion if they're not exerting themselves a lot. Other common symptoms that we can see, again, you'll see this list is really non-specific. Fatigue, weakness, chest discomfort, poor appetite, weight loss. All symptoms that can be seen with other diseases or other manifestations of scleroderma as well. So just to highlight how challenging it can be to really pick up on this diagnosis if we don't have a high degree of suspicion and close follow-up. And again, to highlight, some patients are completely asymptomatic when we get a CT scan and see that they have inflammation or scar tissue that has formed. So the most important thing that I can impart with you today is do not ignore your symptoms. Do not think, oh, I'm getting older and I'm just getting a little bit tired, or, oh, I'm just recovering from something, even though it's been a couple months since I had that cold, this is probably normal. Be vigilant about your symptoms and talk to your doctor, because diagnosis is often delayed. And when we look in the literature, we see that the delays are many years in some patients, 1 to 2 years in over 50% of the patients. And that time lost is lung function that we might not be able to get back if there's significant amount of scar tissue that's formed. Again, delays can be caused by so many things. Symptoms being minimized, misdiagnosis for more common lung diseases like asthma or COPD, other things that maybe your primary care or your other physicians see more commonly because they are more common. Oftentimes, early imaging findings might not even be reported on the imaging that you're getting done because they're missed by the radiologists that are reading through the scans. And sometimes it can be due to a delay in referral, whether it's because the referral doesn't get placed for a long time or whether because the wait times to get into a specialized clinic are really long. Diagnosis is often delayed. And so again, time lost is lung lost. Be really vigilant as patients for advocating for yourself when you have any symptoms and for making sure you're getting screened for these conditions, because the sooner we initiate treatment, the better the outcomes are going to be. So what type of testing do we do to diagnose and monitor interstitial lung disease? The mainstay of testing includes pulmonary function tests, a high-resolution chest CT, and sometimes bronchoscopy or tissue biopsy. But in general, that more invasive bronchoscopy and tissue biopsy isn't often required in patients that have scleroderma lung disease. It's more commonly pursued for patients that do not have connective tissue diseases, but can rarely be used in scleroderma if there's a real uncertainty about the diagnosis. So we're going to start with pulmonary function tests. I'm sure most of the people in this room have had these done and kind of know what it takes to go through these. These are not easy tests to perform. You can see for the most part, it requires sort of sitting in this big box. You've got a spout in your mouth, you've got a clip on your nose, and you've got a really aggressive respiratory therapist that's coaching you through some really challenging maneuvers. These pulmonary function tests are really effort dependent. And if we struggle to coach you with how to do these maneuvers, the results that we get might not always reflect your actual lung function. And so even though sometimes people are like, oh my gosh, that respiratory therapist was screaming and telling me to keep breathe, that's what we want them to do. and if you're not feeling exhausted and wiped out at the end of these tests, we probably didn't get the best information we could have got from them. So here's what a report looks like, and I want to demystify a little bit of what you're looking at here, because there are a ton of numbers. There are a couple that we really focus in on and that I think are important for you to understand what we're looking at. So first I would say look at this percent predicted column. The percent predicted column is generated based on predictions for your age, sex, and height. And in general, we consider anything between 80 and 120% of what we would predict to be normal. So this top number under the plethysmography box says TLC. That is your total lung capacity, the total amount of air in your lungs. That number often is reduced in patients that have interstitial lung disease. And as your lung disease gets worse, your lung volumes get smaller and that total lung capacity gets lower. The next numbers that I would look at are the spirometry category, where it says FVC and FEV1. Those are the numbers of when you're blowing out all the air from your lungs. The FVC is the total amount you blow out. The FEV1 is the amount you blow out in the first 1 second of exhaling. The FVC also tends to reduce in patients that have interstitial lung disease. The FEV1 tends to reduce proportionally. So those are the next two numbers. And then the last number that we really circle in on is the DLCO, all the way to the bottom of the paper. The DLCO is a number that tells me about gas exchange, or how well oxygen and carbon dioxide are moving across the lungs. That is the fourth number that we see in interstitial lung disease that tends to be low. So in general, when we see a low TLC or total lung capacity, we call that restrictive lung disease. And so something you might see in reports would be, a moderate restrictive deficit. That's consistent with what we see in interstitial lung disease when the TLC is low. When that gas exchange number is low as well, that can also be seen in interstitial lung disease and can be significant in patients that have really advanced fibrosis. We can see that number really starts to drop with fibrosis. The other testing that we do that's really critical for making the diagnosis is high-resolution chest CT. So this is the most sensitive, non-invasive test that we can have to diagnose scleroderma ILD. And there are sort of special sequences of images that we obtain to help us make the diagnosis. It's a little bit different than the standard CT without contrast that you might get, but this is another type of non-contrasted exam where we get 3 specific sequences. First, on the left side, you can see we have a patient who is proned or on their belly. On the right side, you can see we have a patient who's supine or on their back. And then for most CT scans, you're probably used to taking a big breath in and then they scan you. We do an extra sequence for interstitial lung disease assessment where we have you take a deep breath out and we scan you at the end of that breath out. And so that gives us some extra information about your airways and how well air is coming out of the lungs that's important to help make a diagnosis of interstitial lung disease. Radiation exposure is something to be considered, and I think it's something that patients always worry about when we think about the need to sort of scan patients over time and monitor lung disease. What I would say, and what a good radiology friend of mine who specializes in interstitial lung disease will say, is that a lot of the studies that have looked at radiation exposure and the risk of cancer are historic studies that came out of times with, nuclear crises and things like that. So the risk for cancer related to radiation exposure is quite low. And the benefit of diagnosing and treating interstitial lung disease early significantly outweighs any theoretical risk of a cancer coming from purely radiation exposure. The radiation exposure that we use now with these kind of newer CT scans is significantly lower than what's been seen in the past as well. So I know that's something that can be a little bit anxiety provoking, but I think from my perspective and from our radiology team's perspective as well, not something that should prevent you from monitoring your interstitial lung disease closely. So I want to talk a little bit about some of the terms that you might see on your radiology report, because oftentimes your CT read pops into your inbox before you've seen your doctor and you're waiting for your appointment in a week or so and you're wondering, what does all of this mean? So let's talk through some of the terms that you might see. This is a scan of what a normal slice of lung. When we look at these CT scans, we're looking from the top down and we're looking at slices of you. And so you can see the front of the scan, the back of the scan, and you can see that left and right are flipped when we look at a CAT scan. In the middle, you have the heart. In the back, you have the spine that's going to look bright white. Anything that looks bright white on a CAT scan is going to be calcified or bone. Anything that looks black is going to be air-filled. So obviously your lungs look predominantly black, and then at some point you'll see an esophagus pop up and there's a little bit of air in the middle of your esophagus as well that will look black. I want to zoom in right here on this sort of set of structures here. So you can see that there's a gray circle in the middle of that, and then there's a small black circle with a white outline. So that is airways and blood vessels cut in different cross sections. When you cut a tube, long ways, it looks like a circle. When you cut it this way, it looks like a line. And so that's what you're seeing here. And you can see that your black circle is going to be your airway, where your gray circle is going to be your blood vessel. Those are normal structures in the lungs. This is a patient that has Scleroderma ILD, and what you'll notice on the CT scan are there are lots of fuzzy gray. This is a predominantly inflammatory CT scan where there are areas of ground glass that have been outlined in those blue arrows for you. Ground glass is what you know it to be, right? So we've all seen ground glass candlestick holders like what's pictured here. You can sort of see through it and you can see what's behind a ground glass candlestick holder, but you can't see the architecture behind it perfectly. And that's what ground glass on a scan is as well. I can see those areas of gray shading there and I can see what's behind it, but I can't see that structure perfectly behind it. That's ground glass, and in general, when we see ground glass on a CAT scan, that tells us that there is inflammation in the lungs that can potentially be reversed. What you might see on your radiology report in addition to ground glass opacity is GGO. So those are some of the terms that you might see that can tell you about inflammation in your lungs. This is what fibrosis looks like. So this is that other flavor of lung disease. We talked about the inflammatory flavor. Here's your fibrotic flavor. What you can see here are these areas where the normal airway and blood vessels have fibrosis that have been laid down beside them, and that fibrosis over time puts pressure or traction on the airway and pulls the wall of that airway open. And it becomes really big and distorted and very prominent on CAT scan. And so that's what you're seeing here are dilated abnormal airways that have been pulled open by scar tissue that has been laid around outside of those airways. We call these honeycomb cysts because they look like honeycomb, as you might imagine. And we also say that there is traction bronchiectasis when you can see dilated airways that have been pulled open. So those are some of the terms that you'll see that are associated with predominantly fibrosis on a CAT scan. There are some patients that have a combination of inflammation and fibrosis on a CAT scan. And so here's another example of what that might look like. You can see that there are some areas where there is some lacy looking areas where there's lots of sort of gray hash marks. That lacy looking area is something called reticulation or reticular opacities. This is another feature of fibrosis in addition to those honeycomb cysts and that traction bronchiectasis that we showed on the last slide. And then we also see that there are areas of sort of lighter gray that arrow has pointed out that signifies ground glass. So it doesn't have to be a one or the other. And in fact, many patients will have a combination of inflammation and some amount of scar tissue. Our hope is always to catch things when they're more inflammatory and can be reversed, as opposed to the later stages where there is more fibrosis that cannot be reversed. The last thing to mention is bronchoscopy and or tissue biopsy, which hopefully shouldn't be something that is routinely used and really shouldn't be. Bronchoscopy is a procedure in which we give medicine through the IV to kind of make you feel comfortable and put a camera that has, or a long flexible tube that has a camera at the end of it through the mouth or the nose and into the airways. We can inspect the airways, we can instill sterile fluid into the lungs and suck that fluid back out, send it off to the lab, look for infection, look for the distribution of blood cells or immune cells, and we can get some information about your disease from that perspective. We can also take a small forceps and take biopsies of the lungs if needed. Again, what I'll say is for scleroderma, if you have a diagnosis of scleroderma and you have imaging findings consistent with interstitial lung disease, you really do not need a bronchoscopy for diagnostic confirmation. This procedure is used more commonly in patients with scleroderma when we are concerned about other things that could be coexisting with the interstitial lung disease. So specifically, infection can look like ground glass or that inflammation pattern that we saw. And if we're unsure of whether this is progression of your lung disease or a new infection, that might be a reason where your doctor would recommend bronchoscopy to differentiate between those two things. But in general, making the diagnosis of scleroderma lung disease is done with pulmonary function testing and imaging alone. So how do we treat this? I think this is kind of the bulk of what I really want to talk about. There are multiple different modalities that we use to treat interstitial lung disease. Immune suppression is sort of the mainstay, and it's similar medications to what many of you use for other manifestations of your scleroderma. So we'll start with immune suppression. This is a flowchart that comes from a recent guideline that came out by the American Thoracic Society that was published in 2024. And there are several different medications that are recommended for the treatment of scleroderma lung disease. There was a strong in favor recommendation of mycophenolate, which has good data to support its use and good data to support a reduced rate of lung function decline in patients that have scleroderma. Many of you might be on mycophenolate already for other manifestations of scleroderma, and it's nice to get two benefits for one medication, because as you know, all of these medicines are suppressing the immune system and have their own host of side effects. And so it's always nice when your rheumatologist and your pulmonologist can work together to choose one of these medicines that will maximize the number of manifestations of your disease that it can treat. So when do we start treatment? In general, with mycophenolate, we know that there is improved lung function at 2 years. It's better tolerated and has improved survival compared to cyclophosphamide, which has very good data to support its use in scleroderma as well. And so oftentimes that will be one of the first medications that we choose. This comes from a clinical trial that looked at mycophenolate compared to cyclophosphamide, and you can see the mycophenolate line on top has improved survival compared to cyclophosphamide. So in general, we tend to choose mycophenolate over cyclophosphamide for patients that have scleroderma ILD. This medication is dosed as 500 milligrams twice a day at the beginning, and then if you're doing well from a side effect standpoint, the goal is to get you on a dose of 1,500 milligrams or 3 tablets twice a day. There are side effects that have to be monitored. So diarrhea or GI side effects tend to be a common one, increased risk of infection, and then increased risk of certain types of cancers, particularly skin cancers. So important that you're having regular skin checks if you're going to be on this medication. Another important thing to note is that this medication is a teratogen. So for women of childbearing age, really important to talk through that with your doctor before starting this medication. And then, as many of you know, this medication does require monitoring. So your blood counts and liver function tests need to be monitored every 3 months because mycophenolate can reduce blood counts or cause changes in your liver function test. And so that would be a really important thing to make sure that you're getting done. Rituximab is one of the other medications that has been recommended and has good data to support its use in scleroderma. There was a meta-analysis that looked at 3 available trials that had studied the use of rituximab in patients with scleroderma and found that their forced vital capacity, or that total amount of air that you blow out when you're doing your pulmonary function tests, declined at a slower rate in patients with rituximab compared to those that were getting placebo at both 1 and 2 years. There were no significant differences in survival, though. This medication is dosed as an injection, typically on day 1 and day 15 every 6 months, and has a side effect profile as well that needs to be monitored. So certain types of infections like hepatitis B can be reactivated on this medicine, so it's important to be screened for that before starting. You can have infusion reactions, of course, increased risk for infection, and then there's a very rare neurologic side effect called progressive multifocal encephalopathy that needs to be monitored for. Very rare, but can occur. And then similar to mycophenolate, this medication does require screening, so blood counts prior to infusions and monthly if you're receiving this. I think one other important thing to note about rituximab is that the effect on the immune system that happens with this medicine lasts for much longer than, for a long time after your last dose, I should say. So there have been data that have shown even a year after your last dose of rituximab, your immune cells are still suppressed. And so it is a really powerful, wonderful medication that can treat your lung disease very successfully, but the immune effects are something that need to be considered in patients that are on this medicine. Tocilizumab is a more recent medication that had a trial in 2020 supporting its use in scleroderma, and it's shown improved lung function at 2 years. Here's a graph from the FOCUSed trial that looked at this medication back in 2020 and compared it to placebo, and you can see that tocilizumab line on the top, patients had significantly less of a change in their lung function from baseline compared to those in the placebo group, who you can see lost lung function over time. This medication is an injection. It's dosed 162 milligrams every week. There are certain side effects that have to be monitored for, like diverticulitis or inflammation in the GI tract, infection, hepatitis, and rarely you can have anaphylactic or allergic reactions to the infusion itself. And similar to the other medications that we've discussed, requires screening tests for infections prior to starting the medication and regular lab monitoring once you're on the medication to monitor for toxicity. So moving into the next category of medications, antifibrotic medications. These are medicines that your lung doctor specifically is going to be talking to you about. In scleroderma, there is a medicine called nintedanib, or Ofev, that was approved in 2019 based on the results of this census trial. And so what they found is that patients with scleroderma that were treated with nintedanib, or this antifibrotic medication, had a reduced annual rate of lung function decline compared to patients that were not taking this medicine. Like I mentioned, nintedanib is an antifibrotic medicine, which is a bit of a misnomer. As I mentioned before, nothing can reverse fibrosis in the lungs, but this medicine can really help slow the rate of progression of fibrosis over time. And so that's what we see here. And based on the census trial, this is a medication that your doctors might think of adding on to your treatment if your lung function is declining despite treating with immune suppressants. In general, the guidelines would say that this should not be a first-line treatment for your scleroderma ILD, but certainly is something that should be considered as an add-on therapy for patients that don't have the desired benefit with immune suppression. There is one other antifibrotic. So now actually there are two other antifibrotics on the market. Another just became approved about a week ago. One is called pirfenidone or Esbriet, and then very recently a new medication that you might be hearing about on commercials or things like that called nerandomilast became approved for patients that have idiopathic pulmonary fibrosis. But those two antifibrotics at this point in time are not approved for scleroderma. So as of right now, it's really just nintedanib that we have in the antifibrotic category as an add-on therapy. Supplemental oxygen is important to talk about. So as your disease progresses, or if your disease progresses, what we might find is over time, your oxygen levels can become lower and you might develop a need for supplemental oxygen. The studies have shown that in patients that have a resting saturation lower than 90%, there is a mortality benefit to starting supplemental oxygen. And so we monitor for that very closely with 6-minute walk tests where we have you walk back and forth in the hall as quick as you can for 6 minutes. We monitor your oxygen at the beginning and the end of the test. And if at any point your oxygen drops below 90%, we talk to you a little bit about supplemental oxygen. And again, like I said, data outside of scleroderma has shown that this can improve survival. There's not specific studies within scleroderma that show it improves survival, but from extrapolating from other databases, we suspect that that's the case as well. And it is standard of care to start oxygen for anybody that has a resting level below 90. If your oxygen only drops with exertion, but not at rest, it's less clear about whether or not we should start you on supplemental oxygen. There is data that suggests that your quality of life and breathlessness is better with supplemental oxygen. And so I will say for most of my patients, we do start oxygen even if it is only exertional or activity-based low oxygen levels. But there are some patients that feel very strongly that they don't want to start oxygen yet. And so it's a discussion that we have if you are only dropping below 90 when you are exerting yourself. The next thing that is really important to talk about is pulmonary rehabilitation. So pulmonary rehab is essentially physical therapy for your lungs. It's a supervised exercise program that includes specific breathing techniques, exercise training that is really focused on high intensity exercise as opposed to low intensity. So things that are getting your heart rate up and sustaining that heart rate response throughout the duration of the activity is really what we want to focus on for this type of lung disease. They also provide health education, psychological counseling, and nutritional counseling to make sure that you're sort of optimizing the nutrition that your lungs need to work effectively. It tends to be 2 to 3 sessions per week for somewhere between 1 and 3 months. It's offered at the hospitals. There are freestanding pulmonary rehabs all over the city and suburbs. Anything that you go to is good. Oftentimes patients say, I'm coming from far, but should I drive into the city to see you guys? Anything that you'll go to and do is best. And so don't worry about sort of finding, driving out to an inconvenient one. Go to where you'll go and get the exercise. There are many documented benefits, including increased walk distance, less shortness of breath, and improved quality of life on patient-assessed quality of life scores. So lots of reasons that you would want to add this on to the treatment of your interstitial lung disease. And the really important part is patients often ask, well, when I finish the program, am I just going to go back to feeling how I did before? There are studies that have shown that the benefits persist for at least 6 to 12 months after you finish the rehab program, and longer if you're going home and doing those exercises that you learned. The goal is really just be active. Any activity that you do counts. Anything that's getting your heart rate up and exercising your respiratory muscles, strengthening your respiratory muscles is going to be really important to your lung disease. So I'm going to briefly talk about a couple, 2 last treatments, stem cell transplant and lung transplantation. I think you had a talk earlier today on stem cell transplant, so I'm going to kind of go through this very quickly. You guys probably discussed the Scott trial, which compared cyclophosphamide to stem cell transplant in severe scleroderma. They did find that there was improved survival in the transplant group, but there was lots of toxicity associated with the therapy. So the big thing that I'll just reiterate from what you heard earlier today is this should be considered at expert centers only. This should not be something that you're looking into at a center that doesn't have significant experience with this, because stem cell transplant has significant toxicity associated with it, and you want to make sure you're at a place where the team knows what to do, knows how to manage and screen for those complications, and knows specifically how to manage that in patients with scleroderma. Last, I'll talk a little bit about lung transplant. This could be a whole talk in and of itself, and so I'm going to start to try to hit the highlights. ILD is actually the most common indication for lung transplant now, and it should be considered as a palliative option for extending the life in patients that have advanced and particularly fibrotic interstitial lung disease. People often think of lung transplant as sort of a cure to their interstitial lung disease, but we know that in general, the median survival after lung transplant is only about 5+ years. And so this is really something that you should think about more as a palliative option as opposed to a curative treatment. Candidate selection is very, very challenging, and there are many different things that go into determining if someone is even a candidate for lung transplant. As you might imagine, the burden of the surgery, this is a surgery in the chest. It requires a major incision. It requires a long amount of time on anesthesia, which can often be challenging for patients that have interstitial lung disease, particularly those that are on supplemental oxygen. And so this isn't a simple procedure that you're going in for, like perhaps a bronchoscopy might be. This is a really significant surgery and requires a certain level of fitness, a certain age, a certain, patient profile to really ensure that you are going to have a good outcome with this type of treatment. Age is a very good predictor of who is going to do well with transplant. And we know that the older you are, the worse survival is post-transplant. Many programs have sort of a tentative age cutoff. At Northwestern, 75 is sort of our tentative age cutoff. There are other programs that really start to worry at age 65. And so this is something that if you have really significant lung disease, we should be thinking about earlier rather than later. But again, so many challenges in terms of kind of the workup that goes into this. Referral should really happen before the need is urgent, because the evaluation that one goes through when they first meet with the transplant team to assess candidacy is extensive. They will need to make sure that you don't have significant coronary disease. They will need to make sure that you don't have significant pulmonary hypertension, which is another pulmonary complication of scleroderma. They will want to think about some of the other comorbid conditions that you have that might challenge your recovery, like poorly controlled acid reflux. All of those things have to be carefully assessed. And then they will also want to make sure that you don't have any underlying cancers or any other life-limiting conditions, and will want proof of that with a very invasive workup. They'll want you to get your colonoscopy done. They'll want you to have your arteries of the heart interrogated with catheterization procedures. All those things are really important parts of their candidate selection to make sure that the people that we offer this type of treatment to are going to have success with it. When should your doctor consider referring you, I think is what really people want to know. If you have advanced lung disease that has failed to respond to the maximum treatment, meaning your doctor has put you on one immune suppressant, they've added on another, they've added on an antifibrotic, you've really exhausted those list of medications that we talked about, you've gone to pulmonary rehab, you're using supplemental oxygen, you've done everything that we have, medically to offer, we should be thinking about transplant. If you have symptoms constantly during your activities of daily living, so if you are someone who is so symptomatic that, taking a shower makes you extremely short of breath, we should be thinking about this. If you're using supplemental oxygen, if your life expectancy is limited, so if your team suspects that based on your lung function testing, your symptoms, your CT scan, that your life expectancy is less than 2 years, that would be a candidate that we would think about for this therapy, because like I mentioned, median survival is about 5 years with transplant. And We want to make sure, like I mentioned, that you have no other life-limiting medical conditions like an active cancer. That would not be appropriate for lung transplant because of the amount of immune suppression that you would need following lung transplant, which could certainly complicate any type of cancer diagnosis. And then importantly, we want to make sure that patients have an adequate social support system. Lung transplant is a huge undertaking. It requires a hospital stay during the time of the transplant. It requires many trips back and forth to the hospital with multiple bronchoscopy procedures. It's a very involved treatment, and we want to make sure that patients are set up for success, that they have the support, people to take them to the hospital, people to take care of them when they're recovering from a major surgery. This is not something that anyone can do by themselves. And so making sure that you have that adequate support system, seeing how the transplant team can help you identify people to help make this treatment successful is really important. Last couple of therapies I'll talk about are coexisting medical conditions, and I know you've had a talk on immunization, so I'll kind of gloss through that, but it is also really important to think about tobacco use, obesity, and congestive heart failure, which are all medical problems that can complicate your lung disease and make things worse or look like they are progressing due to other reasons. And so just making sure you've got a good primary care doctor to kind of keep track of some of these other things, and that your pulmonologist is talking to you about smoking cessation if you continue to smoke, or obesity management if that is a concern for you, is really important as well. So with that, I will say thank you so much for your time. I know it's the end of the day. I really appreciate you staying. I'm happy to take questions if we have time. And I've got my contact information up for any of you guys that have questions you want to reach out to about offline. Thank you guys so much.